Wheezing is actually something we see at least in a pediatric office, really frequently. And when we think about what wheezing actually is, it's a relatively high-pitch, whistling noise. So if you forgive me for a second, I'm going to give you an example that's an inspiratory and expiratory. Wheezer flew through a narrow door. Compressed segment of a small area becomes turbulent. This causes vibration of airway walls, and this vibration produces the sound for wheezing. Now, wheezing is more common during expiration. During expiration alone indicates milder obstruction than wheezing during both inspiration and expiration, which suggests more severe airway narrowing. Now, by contrast, turbulent flow over through a narrow road segment of the large extrathoracic airways produces a whistling inspiratory noise that we call stridor, and that sounds like a scary noise. Yes, that's so. Now I remember, as a medical student, I thought, somebody's wheezing, it's asthma, or maybe it's COPD. Are there other things we need to worry about what was wheezing? Well, it's a really great question, and I'm sure you've heard the saying, not all that wheezes is asthma. So, there are many other causes of wheezing. So let's go back to thinking about why this is happening. So small airway narrowing may be caused by bronchoconstriction there. Also maybe mucosal edema external, Russian or personal obstruction by a tumor or a foreign body or thick secretions. So as you've mentioned, the most common causes are to one COPD, and the other is of course asthma. And when we think of asthma, we really want to remember that there are a number of triggers for asthma itself. So asthma can be triggered by exercise, allergens, upper respiratory infections, cold air, and any one or combination of these can be triggers for an individual, and to keep this in mind, I'll help us when we get to evaluating the patient. Now, as we've already said, wheezing can have other causes also, so it can occur in disorders affecting small airways, such as heart failure, which we term cardiac asthma, and a full axis, or toxic inhalation. And sometimes even a healthy person who has no prior history may manifest some wheezing with an acute bout of bronchitis, and this is short-lived. And then in children we want to always consider bronchiolitis can lead to rethink as well as foreign body aspiration, okay? So, number of causes. So, how do we approach the diagnosis? We need to ask a lot of questions about those. Yes, absolutely. So, one of the things to remember, and I always, when I'm teaching residents and medical students, one of the first things I tell them is when they walk in a room with a patient to assess immediately whether they are okay, or whether they need help immediately. So this is a particular significance with wheezing, in that if a patient is in significant respiratory distress, we need to recognize this and understand that evaluation and treatment can actually proceed at the same time. So what kind of history do we want to obtain? What we should be asking whether wheezing is new or recurrent. Had before, particularly when the diagnosis is unclear. The acuity of onset, whether it was abrupt or gradual, is important to know temporal patterns such as whether it's persistent or intermittent, or whether there are seasonal variations will help in understand what the etiology is and what provoking or exacerbating factors there are for the wheezing, such as your eyes, allergen exposure, cold air, exercise, important associated symptoms, items, shortness of breath, fever, cough, sputum production. Now, when we look at review of systems, we want to be thinking about signs and symptoms of causative disorders. So this would include fever, sore throat, run-in area, which would make us think of a respiratory infection, orthony, paroxysmal nocturnal dyspnea, and peripheral edema of course would lead us to heart failure, night sweats, weight loss, fatigue. We think about cancer, nasal congestion, itchy eyes, sneezing, and rash. We'd be thinking about allergic reaction, vomiting, hyper and swallowing difficulties would make us think of just gastroesophageal reflux disease with aspiration. Now, with past medical history, we want to be asking about conditions known to cause wheezing, particularly asthma, COPD, and heart failure. Patients with known disease should be asked about indicators of disease severity, such as previous hospitalization, intubation, or ICU admission. And then also conditions that predispose to heart failure are identified, including atherosclerotic or congenital heart disease and hypertension, and then of course, smoking history and exposure to secondhand smoke should be noted through. A lot of questions have. To be honest, sometimes I have to remind myself to go back and ask those things after I've stabilized it on the physical exam. tell us what's important in the pulmonary exam and maybe if there are any extra pulmonary finds, sure. And of course, once again with physical exam, the immediate urgency of how the patient is looking is very important to take note of. Vital signs should be reviewed for presence of fever, tachycardia, tachyemia. And, of course, if there's low O2 saturation, this is something we need to address right away. Now, if there are any signs of respiratory distress, and to our students out there that would be accessory, muscle, use and intercostal retractions. Ocean cyanosis, of course, decreased level of consciousness or even fearful look should immediately be taken out of the examination. Focuses on the lungs, particularly adequacy of air entry and exit, and symmetry, or lack thereof of breath, sound and localization of wheezing. So it's a diffuse or is it localized? Is it inspiratory and expiratory or is it not? Any signs of consolidation should be taken note of. So, are there any tachyesis, the dullness to percussion, or do we hear crackles? The cardiac exam should then focus on findings that might indicate heart failure. So listening for and looking for jugular venous distension, and nose and throat examination should note appearance of nasal mucosa. So the color and the congestion can lead us to whether this is allergies or respiratory infection. And then swelling of the face or tongue. And signs of rhinitis, sinusitis or nasal polyps. The extremity should be examined for clubbing and edema, and the skin for signs of allergic reaction. So, is there urticaria, rash or a TB? This would lead us potentially to long-term allergic reactions. Or, of course, if the patient is in respiratory distress, would really be thinking about anaphylaxis. And then, the patient's general appearance is noted for constitutional signs such as cachexia and barrel chest of severe COPD. Now we know that wheezing is always potentially concerning, but are there any findings that would make us suspect this particularly severe, or any other sort of red flag findings? Absolutely. And we've alluded to them so far, but let's talk about 3 in particular. Number 1 would be accessory muscle use. So, any signs of clinical tiring, decreased level of consciousness. This is something we really have to take note of, and I've done right away. Number 2, fixed inspiratory. 3 and expiratory wheezing. Again, we've talked about inspiratory and expiratory wheezing being an indication of more severe constriction. And then number 3, swelling of the face and tongue. We'd really be concerned about anaphylaxis. And again, we want to be treating this. Immediately got a nice database that with complete history and physical. Can you help us sort out how to figure out what to do with all that information? Sure, in a patient who has a current wheezing, and a known history of disorders such as asthma, COPD, failure, we presume that is a reason for this particular exacerbation. In patients who have both lung and heart disease, manifestations may be similar. So we need to try and figure this out. So neck, vein distension and peripheral edema in corpore, manually can be from COPD and be found in heart failure. And ultimately this may lead to some testing to sort that out when the cause is known as more COPD, a history of cough and post-SOTRAP exposure to allergens, or to toxic or irritant gases such as coal air dust, tobacco smoke. Perfumes may then suggest the trigger, and then we want to be thinking about clinical findings which may suggest the cause of reuse in patients without a known history. So let's think about that for a second. In acute wheezing, sudden onset of wheezing in the absence of your eye symptoms, suggest an allergic reaction. So we'd want to think about acute bronchitis in older children and adults, and bronchiolitis in children. Wheezing suggest focal bronchial obstruction by a tumor or for our body. And of course in small children, we want to be thinking specifically a firm body for system, wheezing manifesting very early in life. Suggest a congenital or structural abnormality, and then persistent wheezing with sudden onset is consistent with foreign body aspiration, as we've mentioned before. Whereas the slow progressive onset of wheezing may be a sign of extraluminal bronchial compression by growing, which patients need testing. And what test do we do? Well, testing really seeks to assess the severity of the wheezing, determine diagnosis and identify complications. So, number of tests we'd want to do would be pulse oximetry to that immediately chest X-ray, sometimes depending on the condition of the patient. Especially if they are looking as if they are in severe respiratory stress, we want to get a PG, and then sometimes pulmonary function testing can be done. Verity is assessed by pulse oximetry, and in patients with respiratory distress or clinical signs of tiring, ABG testing. As we mentioned, are patients known to have asthma will frequently have bedside peak flow. Measurements: patients with new onset or undiagnosed persistent wheezing should have a chest X-ray. X-ray can be deferred in patients with asthma who are having a typical exacerbation. In patients having an obvious allergic reaction on X-ray, cardiomegaly if diagnosis is unclear, and patients with recurrent racing pulmonary function, tests can confirm airflow limitation and quantify its reversible. What are your severity? Methacholine challenge. Testing and exercise testing can confirm OA hyperreactivity, and patients for whom the diagnosis of asthma is a question now for accept his treatment, and we usually say the treatment. Absolutely. First of all, the definitive treatment of wheezing is always treatment of the underlying disorder, but for treatment of wheezing and self, as you've asked, use our dilators. And I'm going to go back once again to what we talked about earlier, is if we have a patient who's in respiratory distress, we can start treatment at the same time as starting to assess them and determine what is causing that wheezing in. This is important to remember. So what bronchodilators do we use? While albuterol nebulizer solution or metadose. Inhalanation can be used. Long-term control of persistent asthmatic wheezing may require inhaled corticosteroids, and trying inhibitors. Corticosteroids also might be required emergently, especially if there's an allergic reaction, and then subcutaneous and inhaled racemic epinephrine are also indicated in cases of anaphylaxis, and then also diphenhydramine can be used again if there's an allergic reaction rate. Well, there's a lot of information you've given us today. Could you help us? Asthma is the most common cause, but not all wheezing is asthma. Number 2, acute onset of wheezing in a patient without lung disease, may be due to aspiration allergic reaction or heart failure. Number 3, reactive airway disease can be confirmed via spirometry. And number 4, inhaled bronchodilators are the mainstay of acute treatment. So, thank you to Barbara. How can we tell when someone is wheezing? And what's the physiology like wheezing? Wheezing. It's actually something we see, at least in a pediatric office, really frequently. And when we think about what wheezing actually is, it's a relatively high-pitched whistling noise produced by movement of air through narrowed airways. So if you forgive me for a second, I'm going to give you an example. It sounds like that's an inspiratory and expiratory. Weak airflow through a narrow door, compressed of a small area, becomes turbulent. This causes vibration of airway.